Get started. Appreciate everyone taking time out of their busy day to join us for this webinar, which is part 2 of a 2-part series, which no problem if you weren't able to join us for the first part. We'll kind of do an overview of what we covered then and then jump into some new content. So this webinar is how to survive and thrive during COVID-19, and we're gonna go over the 5 stages that we've put together here at Luma Health that we're using to gauge COVID-19, where practices are in that between those stages, and some patient engagement and patient access strategies that all different clinics, FQHCs, and health systems can utilize to survive and thrive during this time. A little overview about Luma Health. We're a total patient engagement platform designed for providers and patients to maximize patient outcomes. And we built Luma Health because we're all patients and we believe that it should be easy to see and connect with your doctor and to get the care you need when you need it. And then with that, I will have our presenters go ahead and introduce themselves. Dr. Ekram.
Hi, my name is Ekram. I'm the Chief Medical Officer at Luma Health. And with me is Dr. Jogi. I'll let him introduce himself.
Hi, this is Madhavi. I'm an endocrinologist in Houston. I have a private practice, and we about 5 doctors, and we've been using Luma for lots of functions for quite a while now.
And here's the overall learning objectives today and just a few housekeeping items. We're slated for about 30 minutes, and you do have the ability to chat in any questions. So we will do our best to get to those at the end. And if not, we will follow up with you via email after the webinar. Dr. Ekram, would you like to take it away for us?
Perfect. Yeah, thank you so much. So this is, as Marissa mentioned, this is kind of a part 2 of a prior webinar we had done, and we had kind of laid the stage for that by talking about this framework. So this is a framework that we at Luma Health have come up with, and we've tried to break it down such that it can help clinics understand where they are in this kind of onslaught of this virus coming around, and what that really helps them do is understand what they can be doing at different stages operationally to make sure that they're optimizing what not only patient care, but really optimizing their business at each of these stages. So in the last webinar, we talked about stage 1 and stage 2, which we see now, and that last webinar was already 2 weeks ago, and a lot of the country has actually already moved on from those stages. But stage 1 and stage 2, stage 1 is where it's kind of the state of confusion, where the coronavirus was just coming out. A lot of clinics and states and organizations was just starting to learn about it. Patients were confused. So clinics were starting to get ready and for what may be coming down the road, but not knowing exactly what's coming down the road. And then stage 2 really was when the coronavirus was really starting to peak. And then clinics started to see some early disruption in their services, and they started to understand what can we start doing. And so that's kind of where we talked about last time. And you can go onto our website, and we can share after the webinar more information about those first 2 stages and kind of understanding what clinics were doing with our services. But given that we've kind of moved on to that, I'm going to just kind of move on to what we're going to focus on today, which is really stage 3. And then at the tail end of it, we're going to talk about stage 4 and stage 5. But yep, let's go to the next slide. So it's quite amazing. So what we've been doing is that we have a map that you can find on our website that basically color codes the entire U.S. Depending on our statistics from all of our clients, with what stage each state is at. Now, this is obviously a little bit global, so your local community, if you're in a more metropolitan area, you may actually be lagging or being ahead of the entire state. But based on what at the state level, what's going on, this is how we're kind of color coding, and this is changing on a daily basis. So if you looked actually 2 weeks ago when we did this webinar, almost the entire U.S. was red, and now you can see a lot of the middle of the state has actually moved on to stage 4, which we'll talk about in the next slide. But you can see there's still a decent number of the country is still in stage 3. So what does stage 3 mean? So flip to the next slide. This is where we're seeing there's kind of 3 key things that clients on our practices are looking to do. So the first is and the stage 3. Let me just step back. Just defining what stage 3 is. This is where the infection is at its peak, and so at a state level, there's a lot of regulations around what can be, cannot be done. And this is where there's a lot of the quarantine and a lot of the maximum social distancing rules are being in place. And what this has caused a lot of the clinics to do is essentially close down. And then what this results is that because the infection is at its peak, a lot of the healthcare system, particularly the inpatient setting, the hospitals and the ERs and the ICUs are at maximum or beyond maximum capacity. Whereas in the ambulatory setting, you're kind of seeing the opposite, where there's a lot of the services are shut down, and then they're shutting resources just to provide the essential resources to patients that are who need it at this time. So the kind of three main themes in this stage from an ambulatory standpoint are, first is the testing, screening, and risk management for patient populations, which we'll talk about in a little bit. And then, of course, what is this revenue disruption that's happening because clinics are being forced to, or not being forced, but they're choosing to cancel much of their appointments. And so this obviously impacts their bottom line. And that's kind of driven both from providers wanting to do it because of patient safety or their staff safety, and also patients not feeling safe to come in. So you're getting a lot of unutilized capacity in your schedule, which obviously impacts the bottom line. And the third part of it is trying to figure out how providers can still deliver that care, but in a virtual way. So talking about this, how the cancellations are impacting this, again, this is being driven both from the patient side and from the provider side. So we've seen a very massive uptake in the amount of cancellations that are happening. And it's interesting, it kind of varies by state to state. And part of it is, I think, the local, how prominent that infection is, and what the perception of the patients also is, and perception of the providers is. But you're seeing kind of the massive uptake in cancellations to be kind of varied across different regions. And so, for example, in the Southeast, in the Northeast, we saw a doubling of the cancellations, and that's sort of understandable because New York was kind of very hard hit, and so we saw some of that happening early on. Whereas some of the South saw a bump up in the cancellation rate, but not as high. But overall, we can see that the entire state is experiencing increased cancellation rates across the board. Now, what's happening also in line with while this is happening is that there's an increased need to be able to address patients' questions, and not only that, but to screen patients. And so one of the big needs we've seen is that clinics are using our service to be able to send out mass screening questionnaires to see not only around coronavirus related issues. So for example, identifying amongst my patient profile, who are the patients who may have been exposed, who may be having symptoms of corona, and who I can identify to be able to triage them to the next level. But also using this opportunity to also still stay connected with those other patients who may not be impacted directly by the coronavirus, but they still have chronic disease that to be addressed. And so what we've seen is a massive need for the ability to be able to send messages to patients to explain to them, hey, if you're having these symptoms, here's what you can do. We can still help you manage your diabetes or whatever it is. So the ability to still engage patients at a mass level and be able to take information from them so that you can triage them to the level of care. Now, going to the next slide, the other main theme that we've seen is that then once we have identified these patients of who need the next level of care, whether it's coronavirus related or it's not, is trying to figure out how we can deliver that care in a setting where much of our inpatient volume, or not in-person volume is not available or is down. And so we've seen a lot of clinics shifting their care model from being an in-person model to a virtual model. And then some of the pains of trying to figure out how you actually do that. Which are the appointment types that you can do that? Which are the patients who can do that? And and getting the comfort level to be established both on the patient side and the provider side. I think as providers, we've spent our entire lives putting our hands on our patients, and similarly as patients have gotten comfort with that way of delivery of care, but now transitioning to a more virtual model where we can address a lot of other concerns that patients having on the virtual has been a challenge, but we've seen a mass adoption of it kind of out of as a need, because that's what the situations demand. But this is kind of the last main theme that we see at this stage, where we have like mass disruption of our clinic workflows and there's massive shutdowns, is the concept of how we can continue to deliver care to our patients in a setting where we can't physically see them. Now I'm going to move on to the next slide, and Dr. Jogi, who's I'm going to let him kind of chime in here. He's been tackling a lot of this, and he's been tackling a lot of this even before, and he's going to talk about a little bit of experience, both some of what he has done stage 1 and 2, and particularly focusing in stage 3, where I think where his clinic is still standing today.
Yeah, so thanks for going over that. Yeah, I agree with everything you're describing, kind of the structure there. I wish I had put that together in my mind before it all went down. So it was a lot more chaotic at the beginning, which I'm sure it's the case for all the clinics that are listening right now. So initially, we didn't know what the rules would be, and the state hadn't decided, but then we're anticipating we're going to close down, but where are we going to close down? Can we get to our office? Should we not go to the office? Staff, can they come in? Can they not? So there was a lot of confusion, and initially from our approach, we immediately realized it's a bipolar approach. Are we going to see patients from home, at home, or in the clinic? And how do we tell the patients that we are at home and they're going to have to be at home, and that the office is closed? And initially, we had to figure out how to get our phones to work at our homes, how to get the software to work at our homes. So that was all kind of manual processes that I'm sure most clinics by now have done. So now it's at stage 3, where half of our staff is actually 100% of my staff is still at home, at their homes, using my computers and my software there. But my patients don't know. So initially, we didn't know how to tell everybody. Old patient portal systems through EMRs are too slow and don't have enough utilization, I think, by patients for the information to get there fast enough. So Luma is able to get the message there quick, and they have this, we utilize the broadcast hub, made some templates. So essentially we could text everybody on certain days or certain visit types and tell them, look, we're closed, and we could do it for certain periods of time. And that was super useful on a Friday night when you realize that the governor has just shut down your clinic next week. And we essentially said, hey, everybody, on Monday, we're closed, the governor's closed us down, but we're open for televisits. Here's how we're going to do it. And we set up some links, and it was all on a Luma broadcast. So that was, I guess, a huge deal for the first 2 weeks. We were trying to just figure out how to tell people. And since so much information was changing so quickly, we didn't want to send a message out for the next month. We were sending it out day by day. So I tell my manager, here are the 5 things you need to add to that message. And it would go out for the patients scheduled the next day. We had patients scheduled out 3 months, 4 months, meaning they had scheduled these appointments, not knowing it's a pandemic. And now they're not knowing what is happening, right? And our office was hard to get a hold of. The phones may or may not have worked. Our staff is in their pajamas. Are they really going to get to the phones at 7 o'clock as they normally would have? So the communication was really nice, and it could be done really quickly, and we could see real-time feedback, as opposed to a patient portal where you send a message, they might get the email notification, they might reply, they may not even know how to log in. So many complications. Then we started realizing, okay, well, we have certain visit types that are essential. Like I have patients with certain cancers. So I'm an endocrinologist, and they need to get a certain treatment like radioactive iodine, and that can't wait. So 1% of my patients needed to come in. Well, how am I going to make sure that they know, and not everybody knows, to come in? And so we utilized not the broadcast template feature that Luma has, but the patient-specific templates. And we sent messages out saying, hey, I know you're getting messages that say you can't, you shouldn't come in, it's not safe, but in your case, I think you really should come in. So that was all part of stage 1 and 2. Now going into stage 3, we're now trying to figure out, okay, well, our offices are apparently open. I was scheduling patients, as televisits, telling them, hey, I'm going to see you in 3 months or 6 months or a year. I had decided early, okay, I'm going to change how I do things. I'm going to have, I was thinking to stage 5, basically, what do I want my clinic to look like if I don't know what's going to happen? If we don't know that some days we'll have masks and some days we won't. We don't know if the state's going to close us down one day, all of a sudden. So I just said, okay, well, here are the days I'm going to work. And at least for my clinic, I said, for the next 2 years, these are the days I'm working, and I defined it. And when I schedule patients, I'm telling them these are the days I'm going to be there, and unless something changes, otherwise it's still going to be a televisit. Patients generally is most clinics have probably seen, like the televisits. Obviously, you can't do a procedure, and so you can batch your procedures. So I viewed it as a move for efficiency, and all the talking can happen online. And so now that I've been up, I had my first week of clinic this week. So I did it very slowly. In fact, normally my patient visit times are sort of 5 to 10 minute visit intervals, but I made it 30 minutes, which is very, very slow for me. And I had the whole office open, and I was trying to make sure that the waiting room had only a few, like 2 people sitting there, if any, and then patients go straight to a room. Now, how do you get, and I hadn't been in an office in 6 weeks, so I couldn't remember if anything was still working. And so when we got there, I think I over prepared, but there's nothing wrong with that, I think. And so we had patients that had already paid, so we changed some processes of having patients pay via Luma messaging, prepay for their copays and their deductibles by messaging the day before saying, hey, you have a deductible. We don't know what's happening with your insurance, but I think you owe this much. And they've paid ahead of time. So now when they arrive, there doesn't have to be a handoff of a credit card or touching a kiosk. So the testing, screening, and the risk management part of this started the day before with Luma. And then it also started with, hey, 10 minutes before they arrive, Luma is sending, we created a message, and they have these smart messages, action messages through Luma, which I can ask patients, hey, are you having these symptoms? If you are, stay home. If you're not, let us know, and we can either have you stay in the car, or we do have place in the waiting room, and we have a person manning that. Clearly, with a lower volume clinic, we did, at least this week for me, I didn't have to push anybody out to their car. They could either go straight to a room or the waiting room. And using Luma to message them right before and time it to 10, 15 minutes before their visit worked well, and then a back and forth with them, which is just straightforward SMS. And now that HIPAA's lifted, which is hooray, super awesome for me, we don't really need to hide behind passwords. So it's a quick intervention with the patient. And then when they arrive, they've already paid, and they go straight to a room. And then all we have to do is spray down with some alcohol or some wipes, and we're good. Yes, we already knew as a clinic that I was doing for revenue disruption, we already knew that we would get paid 20 or 30% less, or at least that was how it used to be with televisits. Maybe there's a parity happening now where you're getting paid the same amount, but the billing, forget the patients not showing up. The billing department, even in our case, where we have a clinic that had already been doing 30% televisits since 2015, all the rules change daily. So, patients were messaging, not only we're not getting patients because they're scared to come in or they don't know how to get in, but we're telling them through Luma. We can't bill properly. So there is this clear revenue disruption, but at least that's all being figured out now. We're having patients message us saying, hey, I heard that, Trump said, or so-and-so said, or that all televisits are paid for in full, and so I don't have to pay my deductible. Well, that may or may not be true, depending on how quickly your insurance provider has figured this out, but that's a long conversation. And so we use a Luma to just send a template of text saying, I know you have a question about your insurance, but hey, we don't know either. We're just doing the best we can. Thanks for your question. The credit will be sent back to you after it all gets hashed out. Another time saving with Luma direct messaging. And because we're noticing these questions as they're coming up, we can then create automated messages or add it to our COVID webpage, which goes out to all the patients before they even arrive. One thing we're planning on doing is, now I was the first doctor to do that. The rest of the doctors are confused. Should they come in? And I said, yeah, let's all just come back in. We're going to use Luma as our screener. So there'll be a human that's checking the responses. And when the waiting room gets full because they've been sent straight to a room or they can't fit in the waiting room anymore, we're just sending them a message just like a restaurant saying, hey, I've just screened you. You're right in front of me. I'm sorry you can't come in the waiting room. I don't have a room for you. I'm going to send you a test message. I'm glad you got it through Luma. And then when a room is ready or the waiting room's available, I'll send you a message to tell you to come back in. So now patients can go back to their car. They can go get a coffee. They can stay 6 feet apart, however they want. and then they're coming back in. That's our plan for next week. We're in the middle of this right now. So the arguments are, well, is that safer, or is it safer to just schedule way less patients? Well, that goes back to revenue disruption. How do you run a clinic with the same fixed amount of space, the same rent, but you're supposed to space everybody apart by 6 feet? And in a volume-based American culture of revenue, that doesn't work well. So how do you essentially expand your waiting room, but not have a waiting room? And our approach is now, well, we're going to just have people go straight to their rooms and utilize the rooms as part of their waiting, so they're alone in a room. And second, we're going to send them messages and put them outside of our waiting room and let them know when it's safe to come back. Patients are comforted by that. They like that. And a lot of it's being automated through Luma, and this is all evolving right now. I feel like it's going to work well once I have all the other doctors there, which I haven't done yet. We have 5 others that are ready to do and to do their office visit duties. So I kind of took this a little further. So most of our doctors have not come back into the clinic yet. I've already scheduled all my office visits the rest of the year, but I've decided, look, if this is the new normal, then it's unlikely that CMS or private insurance companies, commercial insurance, is going to change how they pay for televisits. So all practices basically have to figure out, A, how do I bill for a televisit? B, how do I bill for an office visit? And as soon as your biller figures that out, the next question is, okay, well, how do I know as a patient coming for an office or a televisit? And what do they want? And Luma takes care of that for us. And after that, let's do the Amazon model. Let's just make it easy for the patient. So if they're on the schedule, they could go either way, office or televisit. And if you do, when we do a screening televisit and we say, wow, you've got a problem that requires me to touch you, I think you can come in next week. Fine. It's just like a regular day. How much disruption you want for your clinic depends on how much technology you're willing to use, is my view of it. If you're unwilling to use any technology, then you've got a problem, because you're going to have a lot less people in your physical waiting room and your office and the same amount of overhead. But if you utilize the technology, I think you can basically use Luma to expand your waiting room infinitely. And therefore the patient, it doesn't really matter how much space you have in your office. It only matters what the patient is coming in for. And Luma knows the visit type, Luma knows the visit status, and can change it for you as necessary. So we're kind of excited to use it now. We're really glad we have Luma as a very simple tool that integrates really well with our EMR to quickly do things that the EMR couldn't do or would have required a human to do. And so our humans are already stressed out. They're wearing masks and gloves and not wanting to touch credit cards. It's nice that Luma expanded their waiting room infinitely and took away any physical requirements. So if the states go back and forth, which we don't know, of open, closed, fully open with fear, fully closed with fear, fully open with optimism, we don't know. We wanted to make it easy as possible for the patient. Not necessarily as easy as possible for the office, but for the patient, as long as everybody's safe. And I feel like utilizing Luma and just converting either TV to OB, office visit, or office visit to televisit, as per patient desire, is probably how we're going to do it. I don't know how it's going to work for everybody else. I've taken it a step further. I've changed my schedule for the rest of my life, actually, and just said, you know what? If I can do a televisit and it's the same as an office visit, and generally for my specialty, there is no emergency. That's why I went into it. So, you know, if a patient can wait an additional 3 weeks or 4 weeks, I'm okay with that. And that's the benefit of my specialty. It's going to be different for everybody else's, but I'm going to work 1 week a month and then take 3 weeks off. And when I'm off, during quarantine periods, I'll be at home doing televisits. But when the quarantines go away, I don't plan to go back. I plan to be on the beach doing televisits from the beach, because I can be anywhere. The patient's the one that has to be in my malpractice covered state. So I'm taking it that far, saying, you know, my stage 5, I've decided is a new type of future for me, but every clinic's going to do something different. And patients are going to have different expectations, not only from the convenience of a televisit, how easy it is, but then, you know, borders no longer mean anything. Distance from office no longer means anything. You're going to probably end up with a hybrid clinic everywhere. And then there's this question of what is the is the revenue going to change? Because prior to COVID, there was no parity. Televisits were about 20–30% less in revenue. So if once COVID or the emergency passes, or whenever somebody strikes a pen to say so, you know, I'm sure revenues are going to go down. And how do you reduce your overhead to match that revenue decrease is going to be a challenge for everybody. And I view it as, if you don't have the technology, you won't be able to match it. Because if you're still brick and mortar, you're going to go the way of Neiman Marcus and everybody else that doesn't have a, you know, a strong online presence or a strong digital presence, because there's no way to sustain it from a revenue model. And I'm talking 5–6 years from now. But right now in stage 3, I feel like Luma provides a lot of good, a good platform to allow for the screening, the testing. The optics for patients and my staff are positive, right? We're trying, we have documentation, and we're trying, and therefore it won't be at odds with revenues for the clinic. So I don't know, that's kind of my thoughts there.
Perfect. No, thank you. That was great. I think it outlines a lot of what our platform can help do, and especially as Dr. Jogi mentioned, you know, I think a lot of clinics will be whipping back and forth based on which way the states go. So I think it's important to understand and establish practices for where you are now, but be able to also be prepared for when you whip back to stage 4 or stage 2 or wherever it is, to be able to kind of have a fluid model to move back and forth. So then we have about 3 minutes left. Marissa, are there any outstanding questions, or should I just we can quickly just touch upon a very overview of the last 2 stages?
No questions yet, so let's keep going.
Perfect. Okay, and so we'll move on to stage 4. So we'll kind of run through this in about a few minutes. And I think Dr. Jogi touched upon a lot of this. So stage 4 really is about when the states start opening up, when your clinics start opening up. This is where clinics will start to understand, to see, you know, what is that mix of how I'm going to run my clinic. And as you can see, based on our data, much of the states, and particularly states in the middle of the country, have transitioned into this stage, as a lot of the restrictions have been lightened, including in Texas and in many other states, where a lot of the non-essential surgeries, for example, are being allowed to be conducted. And so clinics are starting to open up and get comfortable with trying to get patients back in the door. Now, flipping to the next slide. So what do we see kind of the most critical needs is? It's really around trying to figure out now we have this large backlog of patients who we told, hey, look, we have to cancel. I'm sorry, you know, we're close to the next month or next 2 weeks or whatever it is. Now we got to figure out who of those patients we need to get back in. And so really prioritizing the most needed patients. So for example, from a surgical standpoint, the governor's allowed for certain states non-essential surgeries to happen. And so now, but you know, how do you figure out who are those patients that need that non-essential surgery, and how do you schedule them in, and then triage the backlog of patients to figure out who is in most need of your services now. But then at the same time, as Dr. Jogi mentioned, you know, there's still going to be a lot of services that are going to still be offered over telehealth. And so which of those visits that you may have been doing a plethora of in the stage 3, where you had no option except to do them, which of them do you want to continue to do them in telehealth, and which of them do you want to transition back to an in-person visit? And again, we still have to have the background of coronavirus has not gone away. So there's still the ongoing need of engaging the patients in our larger profile or larger roster, of to see, are there patients who maybe don't have a scheduled visit, who we haven't seen for a while, but may still have symptoms or things that need to be addressed from a corona standpoint. And then finally, trying to figure out in this hybrid world, what are going to be the in-office procedures that will be taking place in the quote-unquote next phase, which will be stage 5. So flipping to the stage 5 quickly, this is where we're going to try to figure out, hey, of all the things that we had done in stage 3 and stage 4, which of this will stick, which of it will kind of reverse? And a lot of that will obviously be driven by the legal status and of what is allowed, and also of reimbursement models. So, it's kind of a moving target. But again, this stage is where we're trying to figure out, hey, like, what is our practice going to look like in the post-COVID world, or what we sometimes we'll call it the new normal? How will we be managing our waiting rooms? Now, through this process, patients may have gotten more comfortable with telehealth visits. So now, how do we up our telehealth visit game? as we know that healthcare is becoming more and more consumerized, and so we need to make sure that patients who now can have, it becomes even easier for them to now choose a provider. Now they don't have to leave their house. They can just switch one telehealth visit to another telehealth visit with another provider, and so it becomes even easier for them to choose and to switch. So really understanding how can we take some of the key learnings from what we've experienced going through these different stages and different practices that we've put in, which of them are going to stick. And the last part of it again is now trying to bring in all those backlogs. In the stage 4, we were kind of triaging them to figure out who are the most important patients that needed it access now, but now trying to get back to all the patients that we have canceled and trying to get them back into get them back connected to their providers, get them back access to care. And so kind of juggling this world where we're trying to get back to the normal, but trying to also see what of the previous practices and workflows that we established in the previous stages will stick. And I will go ahead and stop there. And Dr. Jogi, if you have any final kind of words of advice you can share, you being a practice that kind of lives a little bit on the edge, which is great because I think it can be inspiring for some of our other clients and other practices out there.
Yeah, I really feel that regardless of what you decide to do, it's going to be chosen for you based on the need for telehealth in general. Off and on, or what's happened in the last 6 weeks, everybody realizes that if you don't have a digital, whether it's tele or not, but once you have tele anything, you need telecommunications that are in keeping with that, and a digital way of texting, and that's the easiest app. I mean, it's just a question of how do you get your words into somebody's phone so that they can read it quickly, because things will be changing so fast, and the fastest way I can think of is text. And so fast is the answer here. As we all know, it feels like we've been running a marathon, double speed in the last 6 weeks. I feel like I've aged a couple more months. But with these technologies, I feel like it really reduces some of the stress.
Great. Thank you both so much for your time. And we didn't get any questions, but if anyone would like to follow up, they can email Dr. Ekram. And we appreciate you guys taking time out of your day. Thanks so much. And we'll follow up with the recording and slides. Thank you.